Okay, we're recording. Thanks.
Okay, thank you, Jim. Good afternoon, JFS community. This is Director Patton coming to you this afternoon. We have a really important guest that I will ask some questions of as a part of our ongoing effort to make sure that we bring good content and information to all of our employees, particularly during Black History Month, but really any time of the year. It is an honor to have Dr. Odell Owens with me this afternoon. Dr. Owens served 38 years in Cincinnati as an esteemed physician, educator, and leader of various institutions and boards. He's been the CEO of the health equity nonprofit Interact for Health. He was also at OBGYN. He was the medical director of the Cincinnati Health Department, the Hamilton County coroner, and the president of Cincinnati State. In addition to that, Dr. Owens' personal motto is to help people help themselves. As a native Cincinnatian, Dr. Owens is a graduate of Woodward High School and Antioch College in Yellow Springs, Ohio. He spent his third year of college at Mackera. You can correct me if I'm wrong, Dr. Owens. I want to make sure I pronounce that correct. A university in Kampala, Uganda, as a foreign exchange student. So, Dr. Owens, thank you for your time this afternoon. I appreciate you being here to talk to me and also our staff at JFS about health disparities in our community. And I have a couple questions for you. We won't take a lot of your time, but before I start any questions, I just want to say thank you for being here. Anything you want to say in general about the introduction or any clarifications or corrections that you want to make in terms of what I just said?
No, that was fine. I just want to add a couple of things that you gave a list of all my professions, but the one that people forget the most when I get introduced is one, I'm a reproductive endocrinologist, which is a specialty of OBGYN. And since this is Black History Month, I should say that I was the first African American to do a fellowship in reproductive endocrinology at Harvard Medical School. But I created the first in vitro baby in Cincinnati, the first pregnancy from a frozen embryo, and helped the Cincinnati Zoo create the world's first and only in vitro gorilla. So my medical profession, I'm very, very proud of those accomplishments because, my team and I were able to bring to Cincinnati a way of helping women who had been told they would never have a baby. So I've always been concerned about the quality of life for everyone.
Thank you so much. Thank you so much. I appreciate that. So I'll have a question for you. I'll start off with the first question. In your many years of service as a professional experience as a health professional, what are the health issues that have a more acute impact on African Americans in our community?
I gave a talk in, I think in December I was a keynote speaker for the NAACP dinner. And the topic of my talk was, can African Americans be healthy, wealthy, and wise? And the answer was no. When you talk about the health disparities today, they're no different than they were 30 years ago. The numbers may change. We've got some improvements in certain aspects, infant mortality rate, but infant mortality rate is still way too high. Our longevity is not as good as other people. We're number one in hypertension. Black men are number one in having strokes. We're number one in diabetes, the complications of diabetes, including kidney disease. We're number one in kidney disease, but we don't get kidney transplants in comparison to other people. African American women have a lower rate of cancer, but they have a higher mortality rate than other groups. They don't get it as often, but when they get it, they die. Now, again, that's not genetics, even though we understand that a lot of your health is more about your zip code than your genetic code. It's about access to health care. But access to health care does not mean quality care. Mm-hmm. Yes, Obamacare opened the door, but that does not guarantee you quality health care. And African Americans have had a combination of not always having access and not always having quality care. Again, a couple examples of quality care would be, I told you earlier that African American men are number one in having strokes. If you come to the emergency room within a few hours of beginning to suffer a stroke, if they give you a medication that's there in the emergency room, it can begin to resolve the clot that's on your brain. But when African Americans come to the emergency rooms, they're not given that medication as often as other groups. So again, you have us having a disease, not getting the proper treatment. And so the health disparity gap maybe a little shorter, but it's still too wide.
Dr. Owens, help me understand and maybe help the folks listening understand how those kinds of disparities persist. You just mentioned earlier, this has been happening years after years after years. What are the circumstances in your opinion that sort of contribute to these kinds of disparities in the persistence of these disparities?
Well, it's no longer my opinion. I think now when you search the literature, and I was shocked when I looked at the front page of one of the OBGYN journals that states that racism is a big cause of the health disparity.
Mm-hmm.
It is why we're having these problems. It's been institutionalized. You know, there was a study done out of Harvard, and they said, okay, let's look at Medicare patients. So we're looking at Medicare patients, looking at people with the same income level. And these are elderly patients. And they said, let's look at pneumonia, which is one of the number one reasons that an elderly person gets admitted to the hospital. And let's look at how long it takes. Once they're admitted to the floor, how long does it take before the IV is inserted and antibiotics are given? That's how you treat a pneumonia.
Mm-hmm.
Well, the paper showed that African-American patients, it took them much longer for the nursing staff to respond and put the IV in and give them their antibiotics.
Mm-hmm.
So we know racism. Now, the opioid is just the opposite. The opioid epidemic, was almost 90% whites, not blacks. And people say, well, why? How come African Americans initially were not involved in the OxyContin epidemic? Well, because they would come to the emergency rooms or doctors' offices, they would not give African Americans OxyContin or oxycodone because they said, oh, you're just drug seekers. But they gave it to everybody else.
Mm-hmm.
So that's why initially, now we've caught up. We certainly, the numbers are still, but even in Cincinnati, if you were to look at the daily log on drug overdoses, still African Americans are still lower in that category. So you do have incidents of this institutional racism. At one time in Cincinnati, if you were poor African American, you went to General Hospital. It's now University Hospital. So you had access only to maybe one major hospital. At times, African Americans could go to St. Mary's when it was downtown. So again, you're looking at a hospital where you were viewed as the training material. You were simply training material for the interns and the residents. Now that's changed a little bit. The other hospitals now want African Americans. A lot of that is economics.
Right. Are there certain interventions that you've noticed that have maybe started to speak to these disparities or these issues that exist? Are there anything in practice that you've seen outside of training and obviously what you're doing in terms of awareness, making sure people understand the nature of the disparity and why it exists? Are there things that you know of that that can be done or that are being done to really maybe combat that?
Well, I think infant mortality rate will be an example of a program that came out of Children's Hospital. And they began to tackle infant mortality rate by working at a grassroots level, working in areas of the city where the numbers are high, and working past just at the moment of the birth to staying with that mother for the next year. Because if you can delay having one child for another year, you lower your infant mortality rate right off the bat. So they've done other kinds of things, have them get multiple checkups, try to give up smoking. So we have seen an improvement in the infant mortality rate, but the infant mortality rate is still, and let me define infant mortality rate for the audience. Infant mortality rate is the rate in which a group of children, out of every 1,000, how many make it to their first birthday? And for African Americans, it's twice that of whites. Twice that of whites. This is 2022. We can go to the moon. We can do all kinds of things. And yet we have not been able to really cut down on African American and other brown people losing their baby within the first year.
Thank you. Last question here, Dr. Owens. What can we do to be a part of the change, either as individuals or as member of the JFS community? We serve a lot of people in Hamilton County. We're the largest department under the Board of County Commissioners. We touch child welfare. We touch public assistance, food assistance, Medicaid, child support. So we run the gamut. We have a lot of impact in the community. From your perspective, your professional perspective, personal perspective, what are some things that you think either JFS as an organization or individuals that work in this industry, that work in this space, that I think are going to certainly relate to what you're saying and may see it in instances of the work that they do every day. What are some things that people can do on their own to really start to think about and impact these kinds of disparities that you talk about?
Well, I think what you're doing today, education. You gotta let people know. People need to know that 10% of all children in Cincinnati public schools have asthma. But they need to know that more African Americans die of asthma than whites. More African Americans are hospitalized with asthma more than whites. Now, that's also related to poor housing stock, because one of the triggers for an asthmatic attack are roaches and mold. So it's not just one issue, it's the whole collective issue we have to look at about lifestyle. And that's where you do pay attention to the phrase, it's more about your zip code than your genetic code or your DNA code. I think education is an important part. I think too, in terms of JFS, just asking each of your clients, are you signed up for healthcare? Make sure they have. I was amazed when I went to the health department that I found at least almost 5 to 10% of people who would come in who were eligible had not signed up for healthcare. Mm-hmm. And I think that's important because that's where you can get your preventive care, not just your acute care, but your preventive care. And we have to talk more about preventive care than we've had in the past. Mm-hmm. But at the same time, when I was at the health department, I understood that when we would refer a woman to University Hospital to get a colonoscopy, if it rained that day, she may not make it because she had to take 2 buses.
Right.
And she got to take her kids somewhere first to get the child care so she could get over there. And University Hospital didn't understand that. They were hard-nosed. Oh, they just show up. We're not going to give them another appointment. No, got to understand the whole process. Mm-hmm. So when we partnered with an outside group who would provide someone to help shelter them there, those numbers went up because they made sure they helped to get their child to the first place and then make sure they got to the hospital. So we got to look at it in a holistic sense, that it just isn't healthcare. It's about transportation and the relationship that people have with the healthcare system, because a lot of people just don't trust institutional medicine.
Maybe I said this was the last question. I have one.
We have plenty of time.
So when you talk about the trust issue in the healthcare arena, particularly around minorities, what are some things that you think we can do to try to make sure that we're building that or addressing issues of hesitancy or trust in the medical community for underserved populations? What are some things that we can do to maybe start to talk about that or address that?
Well, I think for the medical side first must quit talking down to Black patients. I remember as a medical student at Yale, I would interview a Black patient and I would say, do you have diabetes? And she would say, no, I do have a sugar problem. Well, for years, the people at Yale have been telling Black patients, oh, you got a sugar problem. They didn't say diabetes. Now, why is that important? Well, it's important because if information comes in front of that woman about what she should or should not do for her diabetes, she's not going to pay attention to it because she doesn't have diabetes. She's got sugar. Message come about sugar, she'll pay attention. We got to quit talking down. We got to treat patients that come to big institutions truly as a patient and not as teaching material. When I was at the health department, I introduced a policy that if you refer to one of our medical centers as a clinic, you will find $1. We're a medical center. That begins to show respect right off the bat. Clinic sometimes has that meaning of, we're here just to help you when you're really sick, but you're really teaching material, you have no rights. So we got to make sure that we also got to look at health literacy, how we talk to people. Health literacy isn't just about what you say, but also who you're talking to ensure that we are communicating to people in a way that they understand. And it doesn't necessarily mean not using big words. That's not the case. Oftentimes it's me understanding that people come from different backgrounds and you need to be sure. I'll give you a simple example. People from South America do not like for physicians to pat their baby on their head. Mm. They feel that will stunt their growth. So you guys understand some of the cultural aspect of medicine. Clearly people know that people from India, you could never give them a pork insulin, but years ago that happened until people start getting more sensitive. So we got to have cultural competency along with treating people in a holistic manner.
Thank you so much. Dr. Owens, I really appreciate your time this afternoon. I'm grateful that you were able to give us this information and share it with the JFS family. We've been calling ourselves a family for the last couple of years now, and we really truly believe that. And so I'm hopeful that this interview and this recording will be beneficial for staff. And just want to say thank you for your time. Thank you for Talia for putting this together, and Jim for also helping out as well with this interview this afternoon. Any last thoughts, Dr. Owens, before we close it out today?
No, but I just want to tell the employees of your family, they play such an important role. And I know that certain times they feel sometimes overwhelmed, sometimes they feel themselves being under-resourced or not appreciated by society. But there are people out there like myself who are involved in the community who really know what you guys do and appreciate that you're taking care of the people who need the most help. So again, I'm just so proud and honored that you asked me to participate today.
Thank you so much, Dr. Owens. I'm sure our staff will appreciate those words, and I will talk to you soon. And thank you again.
Good luck.
Thank you so much. Have a good day.
Thank you.